So, colleagues, good evening. Yesterday, we got a lengthy engagement on lipids. Actually, we're looking at basically things to do with lipid metabolism. So, a few things to do with low density lipoproteins. We understood things to do with the conditions that could arise from these being deposited on the cell walls, on the vascular walls, things to do with atherosclerosis, where we're looking at this as a chronic inflammatory disease, which is characterized by the plaque building up on those particular vessels and etc. We looked at a number of risk factors for hyperlipidemia, where we're looking at the environmental factors. We looked at the lifestyle, physical inactivity, looked at the familial or what we could call the genetic predisposition of some individuals to this, but also we appreciated that lifestyle really plays a key role in this. Point to note, we looked at the different drugs in the pharmacological management of this, where we were looking at the statins, we were looking at the bile acid sequestrants, and we saw the different roles they play. Some of them in inhibiting that HMG CoA, which was a 3-hydroxyl 3-methylbutyryl coenzyme A reductase inhibitor. We saw that. Then we also looked at the fibrates, and we also appreciated the role of vitamin B3, or what we call niacin, in also managing the lipid levels and also secretion or production of cholesterol. We saw there are different uses, and we also appreciated the adverse effects. So for friends who didn't really get time to engage with us yesterday live, you could go and review with a recording from somewhere, but also you make sure you do further reading on the same issue, because we couldn't expound everything in 1 hour, in a 1 hour's engagement. All right. So today we are going to still interest ourselves with pharmacological management, but really today we expect you by the end of this engagement to be able to understand the pharmacokinetics and the pharmacodynamics of the electrolyte replacement therapy. Okay, and also we expect you to be able to recognize the therapeutic uses and also the adverse effects and the contraindications. Like you remember when we were talking about some of these things yesterday, that really rarely do we want to term these as side effects, okay? But we call them adverse effects because they are bringing out an effect that is not the primary reason as to why we are administering that drug to a particular individual. I hope we get that one clear. It might look a little bit tricky when someone starts reporting of side effects of the drug, but then these are adverse effects, other effects that are not of the primary reason as to why that drug is being indicated to the individual. Okay, and also we expect you to be able to explain the mechanisms of action and also the physiological impact of the drug used to treat the disorders such as hypercalcemia. Understand that there is a difference between hypercalcemia and also hypocalcemia, which you will see, and also other electrolyte imbalances. Okay, so really we understand that this is not the first time you're going to be looking at this. I believe in your elementary science, you looked at the sodium potassium pump a number of times. You have seen this, and also I remember when we were covering fluid balance in what was that? Was something to do with clinical nutrition. I think we understood and saw a lot of things to do in there. And really, here we shall report that potassium is majorly positively charged ion in the intracellular fluid, or what you could abbreviate as the IC. And the body cannot store potassium, so really you need to have a daily intake of this, since it is necessary however much the body cannot store it. And this is not the only thing that the body cannot store. though I think that one we are very clear. So potassium replacement can be achieved through supplementation, either orally or intravenously using potassium salts. And the examples of these salts, we have the potassium acetate, the potassium chloride, the potassium gluconate, and also the potassium phosphate. And you will see that these are indicated depending on the various severities of different conditions, because regulation is key in management, not only in nutrition, not only in health, but everywhere. Really, regulation is key. Right. Pharmacokinetics and pharmacodynamics of potassium. Really, we are talking about breakdown. We are also talking about metabolism. We are also talking about absorption and etc. When we talk of pharmacodynamics and pharmacokinetics of this, and we are saying oral potassium is readily absorbed, okay, from the gastrointestinal tract, but then, okay, yeah, when it passes through the intracellular fluid, the kidneys play their role. Okay, they play their role. Sorry. Right. I was still saying that once there is intake of potassium orally, we suspect that there is absorption of this potassium into the intracellular fluid. Okay. And when we talk of pharmacokinetics, really, we are trying as much as possible to look at the effect of the drug from, like I had said, the absorption, the metabolism, the distribution. Some people actually, everyone has argued that also excretion is part when we are talking about pharmacokinetics. And also, when we talk of the pharmacodynamics, we are looking at how really the body is dealing with this particular drug that you're putting into the body. And today we are appreciating the role of potassium in this. So we have said the kidneys regulate serum potassium levels by excreting potassium, and I hope we covered how the excretion role of the kidneys when we're looking at kidney disease and acute renal failure and etc. So maybe you would also interest yourselves with that. Okay. Yeah. Potassium quickly moves it, into the intracellular fluid and to restore the depleted levels and also to maintain the balance. And it is essential for determining the cell membrane potential and also excitability. Okay, and it is necessary for proper functioning of the nervous system and also the muscle cells and the nerve impulse transmission. Okay. Yeah. So really, we understand that what is the role of the nerves? The role of the nerves is trying to transmit the signals. Okay. Yeah, to transmit the signals, but really other things to do with the role of potassium. We have the heart rhythm is also key. Things to do with the excitability of the muscles. When we talk of the excitability, we are looking at the contraction, okay, of the different muscles and etc. So we have to understand all this knowledge as healthcare professionals if we are going to deliver it on further. So, pharmacotherapeutics of potassium, when do we indicate potassium? Potassium helps in correcting hypokalemia. When we talk of hypokalemia, we are looking at low potassium levels in blood. Okay, and what happens when there are low potassium levels in blood? Okay, when there are low potassium levels blood, you will see that this will result into various health issues. Things to do, like we had said, since it is responsible for exciting the muscles, we look at muscle weakness, and sometimes, remember, we talked about the rhythms of the heart, then we start to suspect irregular heartbeats. And in severe cases, sometimes people have reported paralysis happening. So common conditions such as vomiting, diarrhea, and excessive urination, and also kidney diseases, burns, and antidiuretic hormones, hormone levels, and therapy with potassium depleting diuretics. These could lead to these levels going low, leading to hypokalemia. So potassium decreases the toxic effects of digoxin. Okay, yeah. So when we talk of digoxin, this is a really a medication that is usually used by people trying to treat congestive heart failure, or what you call the CHF. Other people have called it arrhythmias. Okay, yeah. But so it remember, like yesterday, we were looking at hepatotoxicity by using those different statins in treatment of hyperlipidemia. But really, today we're looking at digoxin, which could have that effect. Of toxicity. It is a drug that is indicated when someone has congestive heart failure. So the normal potassium levels moderate the action of this digoxin, uh, reducing the chances of toxicity. I hope we are clear that far. So for the drug interaction, we are saying potassium should be used cautiously with potassium sparing diuretics and also ACE inhibitors. Okay, yeah, to avoid hyperkalemia. When we talk of hyperkalemia, we are talking about a lot of potassium in blood, which has its also adverse effects. Okay, yeah. So really point to note when we talk of this angiostensin converting enzyme inhibitors, really, we are trying to understand that most of these are used in treating the high blood pressure, and some people have argued really as if it is on the other extreme from the high blood pressure, we're looking at heart failure. Okay, so the angiostensin converting enzyme inhibitors are really those medications that treat those sometimes we are talking about them increasing the serum levels of potassium. Okay, since this angiostensin converting enzyme inhibitor will try as much as possible to affect the increase of the excretion really of potassium. So if it affects the excretion of potassium, then that means potassium will increase. Okay. Yeah. So adverse reactions, we are looking at adverse reactions to potassium often related to the method of administration. Okay. Yeah. So these are route sensitive and also method sensitive. So oral potassium may cause gastrointestinal symptoms, and these we had looked at. And but as well, when you talk of the intravenous infusions, this can cause pain, this can cause phlebitis, and also this can cause it can lead to cardiac arrest if given rapidly. When we talk of phlebitis, we're looking at the inflammation of the different veins. Really, people call it TIS, then some people call it TIS. So it depends on the way you want to pronounce it. Someone could call it phlebitis, and then other people could call it phlebitis. Yeah. All right. So let's proceed. So now we are done with potassium thus far, and like I told you, we can't cover everything in an hour's time. That's it needs you to go an extra mile with pharmacology. You need to understand the different terms. You need to understand the different drugs. You need to understand what is indicated where. What are the drug-drug interactions? For example, the role of potassium and digoxin, which digoxin is the the drug that is indicated when someone is having congestive heart failure, and etc. So, introduction to magnesium, we are saying this is the most abundant cation in the intracellular fluid after potassium, and we are saying it is essential for transmitting. It is approximately 65% of magnesium is in the bone. However, sorry. However, sorry. Yes, please. Hello, did someone want to make a submission? Right, let's proceed. I was still telling us that approximately there is 65% of 20% in the muscle, and we are saying magnesium in the body stimulates the parathyroid hormone, the PTH secretion, regulating the intracellular. levels, and we'll see those in bone resorption and bone demineralization. So these are key mineralization. Okay, and we like moving forward. We have looked at key in transmitting impulses. Okay, so it is key for the nervous system functioning, and we had said that there is 65% of magnesium in the bone and 20 in the muscle, and we had looked at said that we will see that these are partly most of the minerals that are key that we'll have to watch out for when we look at bone demineralization and also bone reabsorption and etc. We had looked at it being key for secreting the parathyroid hormone and also regulating the intracellular calcium levels and also aiding cell metabolism and movement of the sodium and potassium across the cell membrane, or what we call the sodium potassium pump either way. Right. So in the depletion of these magnesium stores, we say that how these stores could be depleted could be due to chronic diarrhea, use of these diuretic drugs, and also a lot of aldosterone in the blood. Okay. So, and they're saying chronic alcohol consumption for the people who use a lot of alcohol and taking a lot of drugs, this could lead to magnesium being depleted from the stores of the bone and the muscle, etc. And we are saying that it is typically replaced with magnesium sulfate that is injected into the individual through the veins or intravenously indicated. And for the pharmacokinetics and the pharmacodynamics of magnesium, we are saying that the magnesium sulfate is distributed throughout the body, though we see that its actions are immediate. And as for the intramuscular administration of the magnesium, it will take around 30 minutes to bring into effect. And we're saying that its excretion is done where magnesium sulfate is excreted and changed in urine, and some could be appearing in breast milk. So this is a key concern that you could talk about when you're talking to breastfeeding mothers, etc. Magnesium sulfate replenishes and also prevents magnesium deficiencies, like we had seen, but it also controls the seizures. And we've seen that it does this by blocking the neuromuscular transmission, etc. So, the drug interactions of magnesium, we had said that magnesium used with digoxin can lead to heart block. Okay. When we talked of digoxin, remember we said that this is a drug that we use in congestive heart failure, or what we call a CHF. And we're saying combining magnesium sulfate and certain drugs can also increase the central nervous system depressant effects. Okay. And also when you use it with the succinylcholine or the tuber sorry, when you use it with a succinylcholine or the tuberculin, it may potentiate or it may lead to prolonged neuromuscular blocking effects. This succinylcholine, really, when we talk about it, it is a medication used to induce really muscle relaxation, or when people are having this short-term paralysis and etc. So that is when it is contraindicated. So for the first two, we have looked at the potassium, and now we have looked at also the magnesium. But now let's interest ourselves with the most common one that we have always been looking at when we're looking at the diets that we limit to the people who are found to have hypertension and etc. And we will see its roles, and we will also appreciate the role of potassium and also balancing these electrolytes. Okay. So sodium is a major cation in the extracellular fluid. We have been looking at the intracellular fluids of late, but now you're seeing that there is extracellular fluid for the case of sodium, and we are seeing the function of sodium for maintaining osmotic pressure. Okay, yeah, and also it is used in the acid base balance. Mm. and also the water balance, and also the nerve conduction and neuromuscular function, and also in glandular secretion. Really, you will see that we've only talked of the neuromuscular function, but really we also have to appreciate that it is not only the neuromuscular function, but we also talk about the muscle constriction, and also we talk about all those other cells, the nerve cells that are essential in the functioning of the cells and the tissues. So we understand that we do not need to consume a lot of sodium for it to bring up its roles. So that's why we need to limit its intake, though we take sodium in moderation, as also the excessive intake of this sodium could lead to problems to do with the hypertension and also other heart diseases like we had talked about earlier. So sodium replacement is necessary in conditions such as anorexia, excessive loss of gastrointestinal fluids, excessive perspiration, and reflux and trauma. When we talk of anorexia, remember we talked about the different forms of the anorexia when we talked of the anorexia nervosa and also the anorexia bulimia, where we are looking at this intense fear of gaining weight from individuals, leading to them restricting partly food intake into their diets and leading to all those other problems that could happen therein. Uh, this extreme limiting of the foods could lead to a person not taking in the foods that are rich in the different nutrients that are essential for the body's survival. Okay, yeah. Right, so now let's look at the pharmacokinetics and the pharmacodynamics of sodium. Oral and parenteral sodium chloride are quickly absorbed and distributed widely throughout the body. Okay, and these can be absorbed in the different routes, but really we will look at oral digestion, though there are sometimes intravenous administration and also topical application. When we talk of topical, we are looking at other sites that could be used to infuse the sodium into the body. So sodium chloride is primarily eliminated through the urine, through sweat, through tears, through saliva. Really, the body fluids could be a key in the role of excreting this sodium chloride. And the sodium chloride solution replaces deficiencies of sodium and also the chloride ions in plasma. For the pharmacotherapeutics of sodium, this is used for the water and electrolyte replacement in patients with hyponatremia. When we talk of hyponatremia, we are talking of sorry, when we talk of hyponatremia, we are looking at very low levels of sodium in blood. Okay, we don't store other things, but when we talk of hyponatremia, we are looking at really very low levels of sodium in blood. So we are saying that when an individual is indicated with sodium chloride, then it could counteract the sodium chloride depletion that is taking place. Okay, so now this is the drug interactions with sodium, what you should take note of or take consideration of when you're indicating this drug. So there are no significant drug interactions that have been reported with sodium chloride, though other conditions that deplete the sodium could include anorexia, like we talked of excessive gastrointestinal fluid loss, we talked of excessive perspiration. When we talk of anorexia, I hope that we had talked about earlier on about the person in fear of gaining weight. But then when we talk of excessive gastrointestinal fluid loss, it could be due to all other things that could be happening. And I remember when we had talked of excretion, we talked of it going through sweating and etc. So really, when we talk of perspirating, we are looking at sweating, where this is the body's way of regulating the body temperature, but with this, it will go with those electrolytes, such as the sodium and the chloride that are therein. Okay. All right. So when we talk of adverse reactions to sodium or the adverse effects of sodium, we are looking at what happens if sodium is indicated. What are the things we could look out for? The adverse reactions to sodium could include pulmonary edema. When we talk about pulmonary edema, this is, we know what edema is. Really, it is a swelling or accumulation of fluid. Okay, yeah, in that particular body part. So when we talk of pulmonary edema, we are looking at accumulation of fluid in the air sacs or the alveoli. of the lung. Okay, and if this is given too rapidly, it could lead to hypernatremia and also potassium loss with calcium, and we are saying it is a major cation in the extracellular fluid. 99% of this is stored in the bone, okay, and it is mobilized when dietary intake is insufficient. That is when you see that if someone is not taking in enough calcium through the diet, these people will have weak bones that could be brittle or could break easily. So forms of extracellular calcium exists in bound, complex, and also the ionized forms, and we are saying about 47% of the ionized calcium is physiologically active. Okay, so for the calcium salts, we are saying these are available in of parenteral. We talked of the total parenteral, we talked of the peripheral parenteral administration, but when we talk of parenteral, we are really talking about introducing a drug, or we are talking about introducing that particular compound in blood or into the body through the extremities, but not through the oral route. It is used for treating hypocalcemia or hypocalcemic states. When we talk of hypocalcemic, we are looking at low levels of calcium in blood. So, what are the different preparations have varying? We are saying different preparations have varying elemental calcium percentages. So, this should be taken in consideration of when you're trying to indicate a calcium supplementation to an individual. We have the oral calcium salts, we have the calcium carbonate, and also we have the calcium citrate. So, what are the therapeutic uses? We looked at the mild hypocalcemia treatment, and also it is a dietary supplement for specific populations such as the elderly who need this. We understand that now the body cannot absorb as much calcium when someone grows older as it was able to absorb calcium when someone was young. Okay, I'm forgetting at what age do bones stop growing or aging. Ever since then, because of now, could have been the ideal. But we are saying that there are now a lot of as possible to prolong life and also improve the standards of living. Hence, we are having less more. The trends of aging people are going to increase. For example, I remember I was reviewing some literature and they are saying we are having around 1.5 billion people. uh, we will be having actually 1.5 billion people by 2030 who will be above 60. That is why you're seeing right now the, the, the youth are more. Okay, but then we are in an era where there are technological advancements. Okay,
I think his network again is not good. Huh?
Hello?
Yes, please.
Hello? Hello? Hello?
Hello.
Yeah. Uh, I think I stopped at this. I think I had stopped at Kalisham. I'm having some challenges with the network. I think if the network goes again, we'll have to just continue from there tomorrow because most of our time has been interrupted.
It's okay.
Right? Yeah. So let's proceed and hopefully the network doesn't. I don't want to give you half-baked information. I don't want to be just reading through things right, for the sake. So where need be, I try to throw in the explanations here and there. But then, if we are going to be doing it at a rush, I would be doing a disservice. So since the slides are more, around 52 slides, let's try and look at a few that the network will allow. But if we get another other disturbances in the network, then we'll have to just leave it at that. Right. We had looked at hypercalcemia being an adverse effect of indicating calcium in high doses to individuals. But we had also looked at the GI disturbances, renal dysfunction. When we talk of renal, we're looking at the kidney diseases, but also the central nervous system effects, or what we call the CN effects. So what are the drug interactions? We are saying calcium binds to tetracycline, antibiotics, in the digestive or in the gastrointestinal tract, forming soluble components or complexes if poorly absorbed. That is where you understand that these tetracycline antibiotics should not be given for individuals who have taken meals that are rich in calcium. For example, for people who have just taken milk, it is unadvisable for you to give them these tetracycline antibiotics. And we're saying this can chelate and form with fluorochloroquine and antibiotics, okay? And calcium supplements can interfere with the absorption of the thyroid hormone replacement medications, but also we are saying these calcium supplements may increase absorption of biphosphonate medications used in treating osteoporosis and also the alendronate and also the risdronate. Okay, yeah. So it is key for you to understand the mechanisms of which these different drugs work, and when are you going to be indicating that particular drug after which meal. You realize that the form of absorption, having the drug is one, administering the drug is one, but then for the drug to achieve its full efficacy or its full effect, then we need to take into consideration all these other drug nutrient interactions or the drug interaction, etc. And we're saying also calcium can inhibit absorption of iron supplements. So what do we do for a person who is having iron deficiency anemia, but then they're also having these different food, their foods are only rich in calcium and etc. So those are things we need to think about as much as possible. And we are saying the dosage varies among populations, and we are saying total daily intake should meet the dietary requirements of the different individuals. I hope we know what the recommended dietary allowances are. These are not things that you're going to be cramming and saying, go feed, but they're things that you need to embrace and be looking at on charts of those words and etc. And also parenteral calcium salts. Okay, so rapidly, we are saying therapeutic use. We are looking at rapid levels of hypocalcemia and hypocalcemic tetany could evolve or could come up. Okay, yeah, we could see elevated levels of calcium in severe hypocalcemia. When we talk of hypocalcemia, we are saying there is no calcium in blood, but then I think there is extracellular presence of calcium. And we're saying the available preparations, we are looking at calcium chloride and also calcium gluconate, which is given intravenous. Okay, yeah. So calcium gluconate is preferred due to its lower irritation compared to other calcium chloride in this. So what are the adverse effects of the calcium chloride? It is highly but also when we do, we can't say that gluconate is the better one, though we know that reporting of less irritating, but also really we are looking at it causing abscess formation if it is administered intramuscularly. When we talk of these irritating pains, it is key for you to discuss with your patient about the particular type of adverse effect that they could choose. Since you know the knowledge of what is going to happen to the patient once you are indicating this, it would be key for you to understand what are the tolerable adverse effects of this individual. For example, let's take calcium gluconate. We talked of necrosis. Sometimes people could call this a particular problem that could happen when there is damage to cell tissues or cell walls with the necrosis that is happening from the calcium chloride. However, when we talk of the gluconate, the gluconate, sorry, the calcium gluconate, we are looking at only sloughing. And when we talk of sloughing, really we are looking at shedding or casting, just like the skin peeling off. Okay, yeah. So only those. So you could discuss these adverse effects with an individual and see whether you could go on hypocalcemia, could be the weakness, the lethargy, someone is feeling nauseated as they want to vomit, people become comatose, but some people could die at the end of the day. Okay, yeah. Uh, now let's look at other drug interactions. There is severe bradycardia. Sorry, there is severe bradycardia when people are given digoxin. Okay, remember when we talked of digoxin, we were talking about this is a drug that is indicated when people are having congestive heart failure. Okay, so when we talk of bradycardia, really we're looking at this condition that to slow down. Okay, yeah, the heart is beating rhythmically lower. We are not per minute, I think, in adults. But if it is going lower than 60 beats per minute per adult, then we say that someone is experiencing bradycardia. Right, and there is known to be incompatibility of the calcium with the phosphates, the carbonates forming those compounds, and also the dosage administration usually given through intravenously, slowly, 0.5 to 2 mils per minute, and also we are saying solutions warmed to body temperature before them being administered. Yeah. indicating these particular drugs or these particular compounds to individuals. All right. So for vitamin D, like we've always been looking at it, it being essential for bone health, affecting calcium utilization, but also we are saying this is indicated when people have rickets, when people have hypoparathyroidism, when people have there it is. So those that are autoimmune disorders. When we talked of the autoimmune disorders, I hope you remember that we are talked about where the body fails to recognize part of itself as its own, leading it to do self-destructions. So the physiological actions of vitamin D, we are looking at it being able to regulate the calcium and the phosphorus homeostasis. Okay, I hope this word homeostasis is not new to us. When when we talk of homeostasis, really, we are trying as much as possible to refer to where the body is trying as much as possible to maintain a stable internal environment despite whatever is happening outside or externally of the body. So, also increases absorption from the intestines and also promotes resorption from the bone, reducing and reduces renal excretion. Okay, so those are the physiological actions of vitamin D, but also it maintains the serum calcium level. So when indicated, when calcium is hope that also vitamin D is indicated alongside it. So that the daily sources is obtained from the diet, supplements. This sunlight really people have argued that it is a precursor. Okay, we do not get vitamin D from the sun, but it is a process that is required for us to be able to synthesize that vitamin D. So we can't say that the rays from the sun contain vitamin D. That wouldn't be science that you're speaking. It could be something else that you're speaking. And there in that slide, we're looking at the recommended daily intake of vitamin D, but we have to appreciate that D deficiency is very common. Okay, in most of the areas where we work, in refugee settings, and also really people do not take a lot of concern in this. So this could happen due to insufficient exposure, like I told you, the sunlight and vitamin D. Really, there is something to do with how it helps in us being able to synthesize the vitamin D. But really, for people who really do not want to get out to get those rays of the sun because they wake up very early in the morning and they go back late at night and they do not have any chance for the sun to touch their skin. Okay? Yeah. When we talk of these vitamin D, I think it is the ultraviolet B rays that are capable of penetrating the skin, triggering that cholesterol to derive vitamin D and etc. I think you'll read that in your biochemistry sometime. So, certain medical conditions could lead to the deficiency where we looked at the celiac disease. I hope we all remember what the celiac disease was. We looked at the inflammatory bowel disease or what we call the IBD. I hope we also remember that the bariatric surgery and also alcoholism and renal disease. Really, the only thing that would interest us here would be the celiac disease, where we were looking at the body's failure to recognize that protein that is found in the wheat. The protein, I think it's gluten, right? Yeah. So the people of this celiac disease, when they consume gluten, it will just trigger an autoimmune response, leading to inflammation and also damage of the lining of the small intestine, and it is so malabsorption. Okay, these conditions affecting the absorption of dietary fat, either Crohn's disease, the cystic fibrosis, all these impair the vitamin D absorption. Okay, and also the bariatric surgery and certain medications such as the anti-epileptic drugs can also affect the synthesis or the absorption of vitamin D. When we talk of bariatric surgery, really here we are trying as much as possible to talk of that type of surgery that sorry, we're trying to talk of that type of surgery for the obese patients who try as much as possible to lose weight. So we are looking at making a different few changes. Maybe here we could also talk of that gastric bypass and etc. Impaired renal function also reduces the conversion of vitamin D to its active form of the calcitriol. I hope that one you will remember. Musculoskeletal and for the non-musculoskeletal symptoms, we have the fatigue, the mood changes, the depression. Understand that rickets could develop if there is known to be a vitamin D deficiencies. So for the diagnosis, we are looking at blood tests of the serum levels, okay, and we understand that levels below 2,000 nanograms per milliliter or 50 nanomoles per liter indicate deficiency of vitamin D, while 20 to 30 nanograms per milliliter, that could indicate insufficiency. Okay, yeah, insufficiency and deficiency are different. A deficiency is caused by an insufficiency. So you could be insufficient in something, but that doesn't literally mean that you're deficient. Okay, so we also have the bone density scan, the dual energy X-ray absorptiometry, or the DEXA. This may scan to access the bone density and also the risk of osteoporosis. So for the treatment, we're looking at moderate exposure to sunlight without sunscreen. You know, sunscreen that the whites usually use to go to beaches. Really, when I say whites, people will sound racist, but okay, even some black people use it to avoid getting sunburns and etc. Right. So oral vitamin D supplements, usually the vitamin D3, the cholecalciferol, is prescribed based on the deficiency severity. And we are saying that this is prescribed according to the patient's age, their health, and also their age. Dietary changes, we're looking at increasing those foods that are rich in vitamin D, such as the fatty fish, the fortified dairy products, and also the mushrooms. And this is where it comes challenging for people, for example, where I come from, and actually me myself, we do not take mushrooms. So you should have a wider understanding of the different foods and what do they contain and how do they help in getting the nutrients into the body, because not a one size fits all. Right. So treatment of the underlying conditions, we are also looking at addressing those underlying conditions that are contributing to the malabsorption. Could be key in you alleviating the function, the alleviating the deficiencies of vitamin D. Or also, we could talk of the renal dysfunction. So, in prevention, how would we prevent this? We could ensure that a person is getting adequate exposure to sun rays, and also the person is consuming diet that is rich in vitamin D sources. And also, we could consider supplementation if someone is not able to take in these foods orally, especially for those people at risk, such as the elderly, and also those individuals that are not exposed to the sunlight. For example, is it in the Arctic region, one of the regions on the earth? Rarely do these people get a lot of sunlight. So we could talk about supplementation for such people. All right. So for the vitamin D pharmacology, we are looking at it being a fat soluble vitamin. Okay. And we are saying it will talk to homeostasis, to the body's way of maintaining the internal environment constant, no matter what is happening externally. I hope you remember that. And we're saying vitamin D exists in two forms, which we have the egocalciferol and then the vitamin D3, which is the cholecalciferol. And also, when we talk of the synthesis of vitamin D, we have what we call uh, we have what we call the endogenous synthesis of vitamin D. Really, we are trying as much as possible to talk about both the vitamin D, the cholecalciferol, and also the egocalciferol, I should say. Uh, I hope I'm still audible because right now I'm seeing my network trying to disappear. Okay, let's proceed. UVB radiation or the ultraviolet B rays that come, and these will convert the 7-dehydrocholesterol in the skin to pre-vitamin D, which undergoes the thermal conversion to cholecalciferol. So for the vitamin D2, this is a plant-based. This is where we get from the mushrooms, and it is also present in the fatty fish, the egg yolks, and the fortified. So when we talk of the light rays, really we're looking at the vitamin D3 and the vitamin D3, which is a cholecalciferol. And for the ecocalciferol, this is what we get from the plant sources. So what are the mechanisms of action? Vitamin D undergoes hydroxylation in the liver to form a 25-hydroxy vitamin D, and further this will lead to a further hydroxylation in the kidneys by 1-alpha hydroxylase producing its active form. Really, we need to understand basically the two forms and how the vitamin D is brought up to its activated form. And we are saying calcitriol binds to the vitamin D receptor, or what we call the VDR, which acts as a transcription factor. And this vitamin D receptor regulates the expression of genes involved in calcium absorption and bone mineralization, immune function, and cellular growth. That's why we saw that vitamin D is essential. So when we talk of the pharmacokinetics, we are saying it is absorbed in the small intestines along with those dietary fats. Remember, this is a fat-soluble vitamin. So bile acids and pancreatic lipids enhance its absorption, and vitamin D and its metabolites are transported in the body bound to the vitamin D binding receptor, the VD, the DDP. Remember, we had the vitamin D receptor, and also now we are having the binding protein, which is the DPP. So once in the liver, the vitamin D undergoes hydroxylation once again by the 25 hydroxylase to form the 25 hydroxylase vitamin D. So further hydroxylation in the kidneys, this we had explained earlier. So what are the clinical applications? We are saying vitamin D supplements are used to correct deficiencies such as rickets, osteomalacia, hypocalcemia, and also we are saying these doses vary based on the severity, and also other patient factors that you need to ascertain before you indicate this particular treatment. Okay, so for the vitamin D and calcium, these are used to maintain the bone health and also prevent osteoporosis. Sorry, sorry about that. Emerging research also suggests that there is a role of vitamin D in immune regulation and prevention of autoimmune diseases. That's when we were talking of the celiac disease, that is when we were talking of the arthritis, these autoimmune diseases that could come. The adverse effects when you take in a lot of vitamin D. Remember, we talked of it as being a precursor or being a requirement in the synthesis of calcium and etc. We're looking at hypercalcemia and also hypercalciuria. When we talk of hypercalciuria, we're looking at high levels of calcium in urine, and also we talk of soft tissue calcification, and toxicity is rarely seen in patients with cystic or called the myocalcin or the calcima. Okay, this is a medication that is derived from salmon calcitonin, similar to the structure of the human, leading to reduced bone resorption and turnover, okay, which is bad. And we are saying by inhibiting tubular resorption of calcium in the kidney, calcitonin increases calcium excretion. And the more calcium is excreted, then that means our bones are going to become fragile and they are going to be easy to break or brittle. Okay, so for the therapeutic uses, we have osteoporosis. It is indicated for established postmenopausal osteoporosis. We understand that when women reach that particular time, they're not absorbing a lot of calcium. So we could indicate that. And also it is administered via the nasal spray or injection along with supplemental calcium and vitamin D. Right. So for the Paget's disease of bone, we are looking at it being effective in the moderate or to severe Paget's disease, providing relief of associated pain by inhibiting the formation of the osteoclasts. Okay, when we talk about osteoclasts, really we are talking about the cells of the bone. Yeah, so these ones are the ones that are really responsible for absorption, I should say. Breaking down the bone tissue involves the osteochondritis, or you've heard about the osteoblasts, and it is we are also looking at the adverse effects. The nasal dryness when it is administered, we are looking at nausea if it is administered where people want to vomit, and also long-term use could lead to neutralizing antibodies and reducing therapeutic effects. Those are the preparations and the dosages that will come to look at looking at the intranasal spray, looking at the parenteral dosage, and also it being administered intramuscularly or the subcutaneous. The alendronate, where we are looking more about bone metabolism in those elderly houses. And trust me, those people pay well. Whoever wants to go abroad and work in those elderly households, they really pay a lot of money. So you go well knowing all this information, and maybe you'll be given a review course here and there, but you will make it work. So alendronate is a biphosphonate used to treat osteoporosis, Paget's disease, and the glucocorticoid-induced osteoporosis. Okay, yeah, and also other bone diseases that are having a characteristic of bone loss. So how does this work? There are B absorption, and its bioavailability is only
Hello.
being able to decrease both the number and activity of the osteoclasts, and it reduces these osteoclast recruitment and inhibits the osteoblasts, which produce the osteoclast inhibitors. Okay, so the therapeutic uses, it is approved in prevention of osteoporosis in postmenopausal women, like we had seen. It reduces bone resorption, increasing bone mineral density. Remember, at a particular point in adulthood, the bones stop growing in length, but what happens to the bone is now mineralization every now and then. The bone density is increasing. So it is considered the first line of prevention. So it helps restore lost bone and also reduces the fracture risk in patients are receiving that therapy. Also, it is a first line treatment, reducing the bone turnover and also the alkaline phosphatase levels. For these adverse effects, we have esophagitis, that is the inflammation of the esophagus, and also this could lead to irritation or ulceration, and also this is contraindicated with people who are having esophageal disorders. Okay, and it's also atypical for femoral fractures. You do not give it when people are having these, and also it is rare, but serious issues may occur if there is prolonged overuse of Okay, so the administration guidelines. What should we consider when we are administering this Alendronate to patients or to clients? It should be taken on an empty stomach, and these are the things we really want health workers and all health professionals always know that the guidelines spell well out when do we take drugs, at what particular time, what do we need to take with the drugs, and etc. You will find people who will be prescribing drugs. This drug works well when you take it with alcohol and etc., which is unethical. That is one, but also you're playing with other someone else's life. Also, we are saying remain upright for at least 30 minutes after administration of valendronate, and also avoid consuming foods, beverages, or other medications for at least 30 minutes after taking this valendronate to maximize its absorption so that it doesn't compete with the active sites with active sites with also those other compounds that you have taken in. So I beg to stop this engagement here. We have been looking at a number of the compounds that are key in electrolyte balance, the sodium, the calcium, the magnesium. We've looked at